on behalf of NNF-J&K and NNF, I welcome Dr. Sanjay Vajir, who is speaker for this talk. He is GM Neonatology and Director of Neonatology of Mother Hospital, Gurugram. And he has had post of EB member NNF, IIB Neonatology Chapter Chairperson, and President Secretary of IIB Gurugram. He belongs to Haryana and I also belong to Haryana. और हरियाणा में तो डॉक्टर संजय वजीर को बच्चा जानता है जिसने पीडियाट्रिक्स पढ़ाई करी है और उसके अलावा नॉर्थ जोन में भी डॉक्टर वजीर आई थिंक वन ऑफ द फ्यू न्यूरोलॉजिस्ट जिसके बारे में सबसे पहले हम लोगों ने सुना जहाँ स्टार्ट किया अब तो न्यूरोलॉजी बहुत आगे बढ़ गया और बहुत सारे न्यूरोलॉजिस्ट हो गए हैं लेकिन ही इज वन ऑफ द पायनियर इन न्यूरोलॉजी इन हरियाणा एज वेल एज नॉर्थ जोन आई वेलकम हिम ऑन द फॉर हिज टॉक
Thank you Manoj for a wonderful and kind introduction. Now we'll probably start. There are very few people in the audience right now, but it's good because it can make interaction possible if you have a smaller gathering. Now the topic today is like neonatal hypertension, and we need to discuss this because we always have been talking about neonatal hypertension in terms of blood pressure values. So we have already talked कि उसका blood pressure इतना कम है तो hypertension, and adults and pediatric critical care we have been talking only in terms of कि अगर उसका say an adult 120/80 is considered normal, so somebody with a blood pressure of 100/70 would consider it as an abnormal. Now, unfortunately, these things does not apply to newborns because of the fact that our baby who is born is going from an adaptation from an intrauterine to an extrauterine transformation. Now, Mohit once kind of brought notice to this kind of a picture, which was a group of neonatologists in England who were sitting on a bar on a Friday and deciding how to decide about the blood pressure values, and then they decided, what do we do? So we'll say, okay, jitna gestational age hai, utna uska kar dete hain. And then someone while sipping beer said, like, well, how do you decide the upper and the down limits? And said 10 ऊपर 10 नीचे कर देते हैं, so that will be the 5th and the 95th percentile, and this got published into a journal, and that got used by British Perinatal Medicine Academy and has been adopted across the world. Now this is a legend, true or false, we do not know, but what it says that this has been followed without an evidence for so many years, and we've been following it left, right, and center. There are normative values which have come over a period of time. We'll not go into details, but we need to understand that you cannot have one single value because a newborn at 28, 24, 29 or 34 is a different value. Then there are certain other factors like a 34 weeks baby maybe like 1 kilo or maybe like 2.85 kilo, a different myocardial function, and also with different kind of antenatal history, maybe something like antenatal say asphyxia or perinatal asphyxia or antenatal chronic hypoxia. That will be a different kind of a ball game for so simple in simple words, the blood pressure values are you should probably not really consider as equivalent to shock. And what we need to think in terms of a shock, because we have looked at the data and people have looked at whether treating the shock at a particular gestational value, does it result in a better outcome? And there have been studies which showed whether if you treat hypertension, some of them say that you probably can make the child worse if you're trying to use, because the inotropes itself can make the child worse. Some people said, like, there are recent 2016 EpiPhase study which said if you don't treat low blood pressure, you're probably going to cause more cerebral injury. And there are certain studies which are ambivalent, which brings us to the notion that one single value of blood pressure in newborns is not good enough to tell us whether we need to achieve that value or not in terms of treatment. Now, when it comes to shock, now shock is different from hypotension. Shock is a circulatory failure where oxygen or nutrient demand of the cell is not being met. Now oxygen or the nutrient has to reach the tissue and tissue has to utilize that oxygen. But for some reasons, either the blood supply is lost or even at the tissue level, the blood supply is fine, but the oxygen is not being extracted enough for the cellular function. There is a continuous anaerobic metabolism which goes on, leads to lactic acidosis, and if it prolongs, then it can lead to a cell death. Now, all of this can happen without the child going into hypotension or a low blood pressure. So as I said, if something is preventing decreased utilization or increased oxygen consumption, despite the blood pressure being normal, so you could still have a considerable shock. So that is why it is important not to think about hypotension, but to think in terms of early signs of identification of neonatal or even in pediatric, the shock which may have a relationship with the hypertension. So you could have hypertension with no shock, you could have hypertension with shock, and you can have shock with no hypertension. So all of these mean different kind of scenarios, and we need to look at how do you identify and treat the shock very early. Now you look at a diagram, when we look at blood pressure in the lowermost part of this thing, this is a combination of a vascular resistance and a cardiac output. Now vascular resistance for pulmonary pressures is easy to identify, but systemic vascular resistance may be just an indirect marker. Cardiac output is again dependent on stroke volume and heart rate. Again, stroke volume is so much dependent on preload, afterload, and contractility. So when we're looking at shock, just saying that we're looking at blood pressure, because if you say if your cardiac output is high and the vascular resistance is low, you could still be in shock and your blood pressure may be normal. Vice versa, if vascular resistance is high, cardiac output is low, you could still have blood pressure normal and shock. So identifying so many things while you're assessing a circulation. So it's not only about looking at blood pressure, but it is about identification of circulatory failure or a circulatory assessment. Now, when we assess the vital parameters in early diagnosis, which help us in identification of shock, are the saturation, the SpO2, which obviously needs to be maintained in a particular value for the oxygen to be delivered. Then the heart rate. Without going into too much of a detail, but if the child has a heart rate which is variable and is in the normal range, which is 120, 160, you probably think that the child who is doing fine. Suddenly, next day you see a child whose heart rate is not showing too much of a variation and is like consistently in the tune of 160, 170, you may still see, okay, that may be the first sign. Often clinically overlooked because you may say 140 kaltha, 160 is still in the normal range, but variability and heart rate increase should be the first sign that clinically is available and often missed. Over-reliance on NIBP, because one of the things is that if you have to manage shock, do an IBP. And NIBP for monitoring shock, because it overestimates or underestimates the shock, and you cannot measure or manage shock purely based on NIBP. It's you use a radial or use an umbilical, whichever way it is possible, but use some kind of invasive monitoring for monitoring shock. Now, the other issue is that, you probably have looked at, but we always have talked in terms of mean. Okay, mean blood pressure kitna hai? 40. Mean blood pressure kitna hai? 30. Now this is one, but there are, as we said, there are two aspects to shock. One is the myocardium, which has to pump and it shows the systolic function, a systolic blood pressure, and a diastolic pressure, which reflects a peripheral vascular resistance. So you need to look at both, because two things assessment can help us. So pulse pressure assessment could be one single thing, clinically available, often overlooked in the assessment. Cardiac output measurement with the echocardiogram. I know there's some people are very fond of it, but we look at, there could be sometimes a normal BP, a low cardiac output, and the vice versa. And people have also looked at whether CO or a cardiac output measurement non-invasively, does it reflect in better outcome? The answer is no. So I mean, definitely, this is a simpler thing. Now, again, when we look at those people who say, okay, and Mohit, with due respect, I know, people say, okay, echo should be done. Yes, it should be learned, and in 30 to 60% of the cases, you may change your management style if you looked at an echo. But, more complex like TAPSE, like, pulmonary acceleration time, and other, complex measurements would make the neonatal care more complex. And it doesn't help when it comes to all the residents, all the nurses in the unit, because all of them may not have the same kind of, acumen and the skills to do a neonatal echogram. What I would suggest that you probably would look at, looking at some of these things. So, just eyeballing. Eyeballing is like, see, this is an echo of a, and you can easily make, this is a normal kind of a child whose like contractility is fine. And this is an IVC which is dilated. You probably can say, you look at how much it changes in inspiration and expiration, but that's again difficult. But if you see, this is a child who is spontaneously breathing, IVC which is dilated, is good enough for not receiving a fluid bolus, and hypovolemia as a cause of shock in newborns is relatively uncommon. Now if you see, compare this myocardium with the first one, this is hardly contracting. So this is a child who has a myocardial dysfunction, and these are 3 or 4 things that you probably can just look at if you're looking at a resident level or at a nurse's level to tell, okay, tell me the myocardium, tell me the IVC. These are some of the things that you can tell, and these are the things which can help you make the diagnosis about what needs to be done further. And as I said, we need to look at the tissue perfusion, and ultimately is the tissue oxygen. Capillary refill time more than 4 seconds is something which is important, but again as a marker of early identification of shock. But at the same time, one must remember that capillary refill time is prone to so many other problems like temperature, like polycythemia, like host of other things without going into details because of lack of time. Lactate serial measurement can help, but again there is a problem with lactate clearance. Sometimes use of epinephrine or norepinephrine can actually lead to impaired lactate clearance, and you may just make ARINS values and urine output. Mixed venous saturation and NRS, I've left it there. These are good to use, but clinically not available, so I'm not going to discuss. So essentially what I'm trying to make is that we need to look at all the parameters, both clinical and echo, to make a diagnosis whether the child is having a shock and what is the pathophysiology of the shock. And if you have a preload which is based on you can give a clinical bolus of 10 ml per kg over 30 to 60 minutes, see a response. But if you see an underfilling on echo, that may be another thing that we see IVC distended, the left ventricle kissing, or the right atrium which is dilated would be against a diagnosis of a volume overload. And afterload, you can measure, as I said, PVR in those cases. Now, coming to management, now I would say, okay, so you look at, I was saying pulse pressure and often ignored. You have a mean blood pressure of 40, 40 and 40 in all the three cases. Now, if you see, the first case is 60 by 26. So the inference here is that if there is a low diastolic blood pressure, mean is fine, and the cardiac output is likely to be high. Now, this is a child where you have an SVR which is on the lower side. You have a case 2 which is like, looks more or less normal, likely to be normal, if your other clinical parameters are fine. And then you have a third case where the difference between the systolic and diastolic is very low. And this is a child who probably has a very low cardiac output and more likely to have a high vascular resistance and a low cardiac output. And again, as I said, this is something that you could probably look at. We need to look at inotropes when we talk about inotropes, dopamine, dobutamine. Usual story was like, give 10 ml per phase of bolus, start with dopamine, go from 5, go up to 20, then add dobutamine, it doesn't work, then talk to the parents, then nothing can be done. That was because we were not knowing what to do, and it is not as simple as like, as we just saw, that there is somebody, the SPR was high, and if you gave dopamine to that child, you're increasing the afterload in the last C section. So you need to understand dopamine, you would probably make it somewhere between 5 to 10. After 10, just change over to some other inotropes or based on the pathophysiology and understanding. Same with dopamine. Adrenaline, norepinephrine, you should consider using along with an inotrope because it's a strong vasoconstrictor. Epinephrine is more vasoconstrictor than dopamine. Vasopressin has been used in some of the cases of resistant shock, mainly known for inotropic action, but one should avoid loading in those with mild hypertension pre-existing. And hydrocortisone we will not discuss, but then of course that's one where the inotrope resistant shock that you would need to understand. Now, few words about each epinephrine and this thing, because as I said, we need to move beyond dopamine and dopamine. And this was a study we did from our unit, and we looked at the use of dopamine and norepinephrine was safe, and this has been published in a couple of recent studies across the globe. The same with epinephrine, a PGI study which suggested that epinephrine was better than dopamine in babies who were less than 30 weeks of life. Vasopressin, the data is limited, but if you have a pre-existing pulmonary hypertension and a shock, this is one of the things that you may try, especially if inotrope resistant shock is available. So I'll just go into the kind of algorithm, and then I stop without going further into the cases. But you need to see if there is a signs of circulatory failure. You need to look at, investigate for sepsis, cardiology, consider if there are other signs. You may choose clinically to give a bolus of 10 ml per kg, and after that, just 2 minutes or finish. I can just finish these two less slides and then. And the blood pressure, you will need to see if the blood pressure improves with the bolus, then you can leave it as such, maybe some amount of hypovolemia. But if there is a normal BP but abnormal finding, this is a sign that you probably have dealing with some kind of a cardiac failure. And based on the diastolic or systolic or a combination, you can choose an inotrope. At this time, you should also consider targeted echo, and then you probably can take help of your consultant or